Good afternoon, everybody. This is Dr. Hart, and I'm here today to discuss schizophrenia spectrum and other psychotic disorders. These patients with these mental health issues are going to have a lot of problems with interpersonal relationships, a lot of problems with functionality, problems keeping an occupational independence, keeping a job, keeping housing, socioeconomic status is going to be difficult to maintain, and a lot of the bias and discrimination or misunderstanding or ignorance falls within these categories of mental health patients with these disorders, just for a lack of misunderstanding. So if you can educate people as much as possible, these patients with schizophrenia, they're not making it up, they're not doing it for attention, they're not doing it so they don't have to work and be on disability. These are true disorders of the brain, okay? And here are, to start out, some of the thoughts, causes, contributing factors that are thought to be a cause for schizophrenia. We don't really know, even to this day, for sure what the true cause is for schizophrenia. Here are some of the probable causes. Genetics, big genetic link. Relatives with schizophrenia have a higher chance of being diagnosed with schizophrenia. There's a biochemical, which is a chemical imbalance in the brain. This is thought to be an increased serotonin, excess of dopamine, abnormalities in neurotransmitters in the brain. So that's the biochemical. The physiological effects might be after a viral infection or prenatal exposure to influenza. Brain abnormalities such as ventricular enlargement. Psychosocial risk factors, stressful events, lack of housing, lack of material resources can cause a higher risk for the patient. And stress that contributes to the severity of the illness. Also, it's thought that the brain of a patient with schizophrenia has less gray matter. Okay, so there's no cure. As far as we know, there may never be a cure for schizophrenia. So we just have to be very understanding, non-biased, non-judgmental when we are treating our patients with schizophrenia. There can be multiple causes, widespread neural dysfunction, along with psychological effects. Treatments are medication, living skills, social skills training, cognitive therapy, rehabilitation, and family therapy. So especially for the family member who is caring for someone with schizophrenia is going to need some help with that, some training on how to deal with that. People with schizophrenia have more chaos in the family, longer hospitalizations, and generally a 25-year shorter lifespan than the general population. There is a high risk for suicide. I'll get into the visual and auditory hallucinations, especially if they are having auditory hallucinations that are telling them to kill themselves. They are at a very high risk for suicide and must be assessed and watched carefully. So the risk for suicide is a very high concern. 20 to 40% of people with schizophrenia will attempt suicide. 5% die by suicide. Okay, so these are all the things I already talked about. Lengthy hospitalizations, chaos. Um, they're causing high costs to people in government agencies because of the number of people with schizophrenia who have to be maintained on Social Security disability, food stamps, and all the government amenities that are costing taxpayer money. Okay, and high risk for suicide. So the nature of the disorder, there is a psychosis, which is part of the schizophrenia. This is a disturbance of thought, a loss of reality, loss of social function, loss of occupation is going to come along with this psychosis. This is part of it, part of the schizophrenia. There may be evidence of hallucinations and delusional thinking, and this can be without any organic impairment. In other words, there may not be anything that show up in the labs or any other diagnostic testing. So there are 4 phases of schizophrenia. The premorbid phase. That's where the person is just generally very shy, withdrawn, doesn't socialize with others, has poor relationships with others. A prodromal phase, okay, is, and this is, again, the DSM-5, this statistical manual for diagnosing mental disorders is used, and how to diagnose these phases. The prodromal phase can be as brief as a few weeks or months, but most studies indicate average length of the prodromal phase is between 2 and 5 years. This is where the patient begins to show signs of significant deterioration in function. So not able to work, not able to function, not able to socialize with other people, not able to deal with being in social situations. During this prodromal phase, the patient begins to show signs of significant deterioration in function. And 50% of the people in the prodromal phase will have depressive symptoms. Next is the active psychotic phase, or the acute schizophrenic episode. Okay, so these go from least to worst, and then to recovery or residual. So active psychotic phase or acute schizophrenic episode, these psychotic symptoms are prominent. This is from the DSM-5 criteria for schizophrenia diagnosis. 2 or more of the following: delusions, hallucinations, disorganized speech, catatonic behavior, negative symptoms, and I'll talk about all of those. A decreased level of functioning in work relations and self-care. So if there's a lack of self-care or personal hygiene, that's going to be part of it, part of the psychotic phase. Continued signs of disturbance lasting 6 months. Schizoaffective, which I'll talk about. Schizoaffective disorder must be ruled out, and bipolar disorder must be ruled out before any diagnosis of schizophrenia is used. It cannot be attributed to substance or drug abuse. I'll talk about all of those. With a history of, if the patient has a history of autism, schizophrenia is only added if there are delusions or hallucinations. Those are the 2 significant things that will add a diagnosis of schizophrenia, are the delusions or hallucinations, seeing things that are not there. And the residual phase follows the active phase, with symptoms of the active phase are either absent, no longer prominent. Positive symptoms may improve, but the negative symptoms may remain. And I will talk about the positive and negative symptoms and the differences in those. So it's not a very positive, not really a very positive prognosis. A return to full premorbid functioning is not very common. And the things that are associated with a positive prognosis are if there was a high level of functioning before the onset of schizophrenia, if the schizophrenia was a later onset, later in life, if a patient is a female, there is more, in the research, more of a positive outcome or prognosis. And there may be significant clinical improvement that only occurs in 44% of patients with schizophrenia. The delusional disorder is where there are prominent non-bizarre delusions. The main ones that I want to speak about here are grandiose. The person is grandiosity, that is where the person thinks they are better than everyone else. Jealous type, obviously jealous of other people. Persecutory type, those are delusions of persecution. This is the most common type of delusion, where people believe they are being persecuted or treated poorly in some way. They think they are being plotted against, cheated, or defrauded. Followed by someone spied on, poisoned, or drugged. Just a quick story. I had a patient in the detox center where I worked. He was having thoughts of paranoid, delusional thoughts that someone was in his attic watching him. And he also thought someone was using his medical or getting into his medical information, is PHI, personal health information. The person may obsess about these things and exaggerate them, whether they're real or imagined, until it becomes their total focus. Repeated complaints may they may be calling the police and reporting these things to the legal authorities. They feel threatened. There may be some persecution toward them in some way. Some examples of patient statements: the FBI has bugged my room and intends to kill me. The government put a chip in my brain to erase my memories. These are also referred to as paranoid delusions. I won't eat this food. I know it has been poisoned. And we had a patient, female patient, in the psych unit where I was taking students. She would not eat or drink anything from the unit because she felt it was the food and drinks were poisoned or had blood in them. Aggression or violence. The patient may get aggressive or violent because they believe they may have to defend themselves or against someone or something that they feel is a threat. Another patient statement might be, everyone here is part of the secret police and wants to torture me. And so a nurse's response to that might be a therapeutic communication response, might be, that must be a frightening thought. We are nurses who work at the hospital and you are in a safe place. Okay, but if the client starts to display violence, starts yelling at other patients and other people, the nurse should ask the other clients to leave the area to keep all patients safe, but provide the client with an adequate personal space until you can get some help. Brief psychotic disorder is a sudden onset of symptoms. This is from the DSM-5. May or may not be preceded by a severe psychosocial stressor, and this lasts less than 1 month. There are substance use-induced psychotic disorders, induced by other substances, street drugs, recreational, LSD, MDMA, whatever, even marijuana, cocaine, heroin may bring on these other psychotic disorders. The psychotic disorders may be associated with another medical condition, or there may be catatonic disorder due to another medical disorder. A catatonic disorder, that's where the person has their movements are distorted. They may have very rigid movements, fast movements, or they may not be moving at all. They may be staying still. They may have fast or strange movements, lack of speech, or other unusual behavior. Treatments for these include tranquilizer medications like lorazepam, brand name Ativan, and diazepam, brand name Valium, or electroconvulsive therapy, which I will cover later on. Other schizophrenia spectrum and psychotic disorders. So similar to autism, there is a spectrum of disorders. There is the lower spectrum and then all the way to the more serious spectrum of schizophrenic disorders. Schizophreniform may have the same symptoms as schizophrenia, but the duration is much shorter. It has to be at least a month, but less than 6 months. And that's how it's diagnosed. Schizoaffective, this is a symptoms of schizophrenia along with a lot of symptoms that are either mania or depression. So here is the part of the nursing process. The first step is assessment. So we're going to start with the positive symptoms of schizophrenia. So positive symptoms are the symptoms that are present or added. So we have normal in the middle, normal symptoms. And then we have, over here we have positive symptoms that are added to someone's, someone's present, how they present. So not typically present in people without the disease. Negative symptoms are referred to as deficits or impairments, things that are taken away by the illness in patients with schizophrenia. Let's start with the positive symptoms. These are delusions, are fixed false beliefs, paranoia, extreme suspiciousness of others. For example, spies are watching everything I do. Delusions of persecution, I talked about already. These are the thoughts that the person is being persecuted against, plotted against, cheated or defrauded, followed, spied on, poisoned, or drugged. The person may obsess about these feelings until it becomes their main focus. Repeated complaints to legal authorities. And magical thinking, okay? Magical thinking is thinking that they're hearing the news on the radio and that person is has control over them and they're thinking their thoughts. So one's thoughts or behaviors have control over specific situations. So my thoughts can control others. That's magical thinking. More positive symptoms. These are disturbances that show up in the person's speech. So there are loose associations. The person goes from one idea to another. They are having trouble staying on topic. Their speech or talking or conversation is all over the place, not able to focus on one idea. They're unaware that their topics are unconnected. When the condition is severe, the speech may even be incoherent. For example, we wanted to take the bus, but the airport took all the traffic. Driving is the ticket. When you want to get somewhere, we all have it in our pockets. Okay? Words put together, but they don't really make any sense. Neologisms are newly invented words. They're invented by the patient, and they really think they're real. But they only have symbolic meaning to that person. For example, patient states she wanted to give me a ride in her new uniform. Another example, patient states, the Shapatulians took my shoes out of my room last night. Okay? And clang associations, these are words in a sentence that take a rhyming meaning. The gold has been sold, or it is very cold. I am cold and bold. The choice of words is governed by sounds, often taking the form of rhyming. Word salad. So these are real words that are put together in a sentence, but they don't make any sense when put together. For example, there's no logical connection. Most forward action, grows life, double, plays, circle, uniform. So just words put together that don't really make any sense. Circumstantiality, delay in getting to the point of the communication because of unnecessary and tedious details. The point or goal is usually met, but only with numerous interruptions by the interviewer to keep the person on track. And tangentiality, this is the patient who is steering away from the topic and demonstrates difficulty maintaining focus and attention. Would be very difficult to get the important information that you need, right, from someone who's going through this. Disturbances, other speech disturbances, perseveration, persistent repetition of the same word in response to different questions. Echolalia refers to repeating words or phrases spoken by another. So you're asking the patient a question, and all they do is repeat what you ask them, the same thing that you're asking them. Repeating words and phrases spoken by another. In toddlers, this is expected, and it's a normal phase of development when your toddler repeats everything you say. But in children with autism, echolalia may persist beyond the toddler years. So this is a manifestation also of autism, repeating things that other people say to them. In adulthood, echolalia is a significant neurological symptom of thought disturbances that occurs in schizophrenia, strokes, and other neurological disorders. Okay, and autism is one of those. These are disturbances in perception. These are the hallucinations I mentioned earlier. They may involve all five senses. We'll talk about auditory. These are false perceptions of sound. Most commonly, these are voices, but the individual may report clicks, rushing noises, music, or other noises. Command hallucinations are voices that issue commands to the individual. Auditory hallucinations are the most common type in schizophrenia. So this is the patient who tells you that I'm hearing a voice that's telling me to hurt myself or others. Okay, so very important that you report that to the doctor and keep that patient and everyone else safe. If your patient reports auditory or command hallucinations, the nurse will ask the client what the voices are saying and what are the voices telling you to do. Okay, so get some more information if your client reports that to you. Visual hallucinations, false visual perceptions, formed images, flashes of light, tactile hallucinations, false sense of touch, something on the skin. Most common is the feeling that someone is crawling on your skin. So if you go to take a blood pressure, okay, of any patient, more specifically a patient with schizophrenia or other mental health disorder, ask permission first, okay, as you would always do, but ask permission before you touch the patient, because they may perceive that touch as harmful and they may act in a defensive manner. So ask permission first before you put on the blood pressure cuff or whatever you need to do, okay, whether it's wound care, whatever you need to do with your patient, putting on the blood pressure cuff, be sure to ask permission first. And then gustatory, false perception of taste, unpleasant taste, olfactory hallucinations, false perceptions of the sense of smell. These are treated with risperidone. I'll talk about some of the other typical and atypical antipsychotics. One of the medications that is used to treat positive symptoms is risperidone. This is an atypical antipsychotic, treats positive symptoms. With auditory hallucinations, the nurse should tell the patient, if your patient tells you they're having auditory hallucinations, it must be scary, but I don't hear a voice. You should keep your patient grounded in reality. There are illusions or misperceptions or misinterpretations of real external stimuli. For example, the patient sees a stick and thinks it's a snake, or they see a cord in their room and they think it's a snake. Echopraxia imitates the movements made by others. And now we're moving on to the negative symptoms. So there are disturbances in affect. Affect is how your patient is going to present to you. What do they look like? What are they going to show you? How are they going to sound when you speak to them? Okay, these are the different types of disturbances in affect. Inappropriate, bland, flat. Okay, there is apathy. Okay, so keep in mind the prefix a or an means without. So for example, anorexia, without appetite. Okay, apathy, disinterest in the environment. Avolition, inability to initiate goal-directed activity. So the a or an at the beginning of the word means without. That will help you determine which ones are negative and which ones are positive symptoms. So that's a clue for you. Okay, apathy, avolition are both negative symptoms. There could be lack of emotional expression, a blunted or flat affect, lack of movement, lack of intonation in speech. So I use intonation when I'm talking. I may go up and down with my tone. So, but a person without intonation is going to just have one steady stream and not be talking with any intonation. Okay? Diminished ability for abstract thinking. They are not able to recognize concrete thinking. They are concrete thinkers. They're not able to recognize abstract thinking. More negative symptoms: lack of interest in skills or lack of interest in being around people. They're not interested in being around people. Lack of insight. Inertia, another word that begins with A, and that's a negative symptom. Inertia is the lack of energy. Lack of abstract thinking ability, and other associated features are here. Waxy flexibility. This is where the person's limbs stay frozen in the position they are placed. So if you put your patient's arm up to take a blood pressure, you take the blood pressure cuff off, and the person's arm stays where it is. That's waxy flexibility. Posturing is where the patient holds odd, rigid, or bizarre positions. There's pacing and rocking. Regression is a patient reverts to a childlike behavior. Eye movement abnormalities are where there is a rapid involuntary eye shifts. There are fast, jerky jumps when tracking a moving target rather than smooth motion of the eyes. Here are some goals examples. Nursing diagnosis example would be disturbed sensory perception, auditory visual, just in case you have to write a care plan or you're a patient in the mental health unit. Goals or outcomes. These are examples of the client will discuss their hallucinations, define and test reality, verbalize an understanding of the voices they are hearing. Okay. Observe for signs. This is the nurse will. This is what the nurse will do. These are the interventions. The nurse will observe for signs of hallucination, listening pose, laughing and talking to themselves, stopping in mid-sentence. Ask them, are you hearing something else? Or are you hearing other voices? You need to ask questions to get some more information at that point. We have had in the psych units where I take the students, many times we have seen patients talk with no one sitting next to them, but they're obviously it looks like they're talking to someone who is sitting next to them. Early intervention may prevent an aggressive response to command hallucinations. Avoid touching the patient without warning them. I talked about that. An attitude. The nurse should have an attitude of acceptance. Encourage the patient to share the content of the hallucination with you. Ask them, what do you hear the voices saying to you? This is important to prevent possible injury to the patient or others coming from the command hallucinations. Do not reinforce the hallucinations. Don't use the word voices. Instead, use they. Let the client know that you do not share their perception. Say, even though I realize the voices are real to you, I do not hear any voices speaking, or I do not see anyone else in the room. It's important for the nurse to be honest, and the patient must accept perception as unreal before hallucinations can be eliminated. Okay, and of course the final step of the nursing process is a reassessment or evaluation for the nurse to determine if their interventions have been successful. Has the patient achieved their goals? Here are the treatments: individual and group therapy, social skills training. Why would a client with schizophrenia need social skills training? Because it is used to help these clients manage the struggles of interpersonal relationships and communication which will be complicated by the inability to perceive responses in others accurately. In other words, they're going to take something you say to them, and their perception is off. So they are going to misunderstand that, and they need to learn how to understand what people are saying to them. So in social skills training, the patient is going to learn about facial expressions, appropriate eye contact, voice loudness and affect, the appropriateness of what they are saying, response time, amount of time talking, things like that. Don't interrupt other people. These skills can be taught through a process of shaping, rewarding. This is necessary because social dysfunction is a hallmark of schizophrenia. Impairment in interpersonal relationships is included as part of the defining diagnostic criteria for the conditions in the DSM-5. Considerable attention is now being given to enhancement of social skills for this population. Okay, let's get into some of the medications. Antipsychotics take several weeks to work, same as antidepressants. There are typicals and atypicals. They're used to decrease agitation and psychotic symptoms. The typicals are first generation, first line, conventional. Those are the first ones that came out. Those are the heavy duty strong ones. Atypicals are second generation. Because of the heavy duty side effects, they came up with atypicals, which are second generation. And then there's even third generation antipsychotics. Antidepressants can also be used, mood stabilizers, benzodiazepines. I talked about the MAOIs. I'll talk about that again in the chapter on psychopharmacology. Phenelzine, which is the MAOI. Patients must avoid foods containing tyramine. For example, corned beef and Swiss cheese sandwich. Antidepressants such as sertraline. Sometimes takes up to 4 weeks for the medicine to bring about an improvement in symptoms. And with antidepressants, as the mood begins to lift, the patient may have more energy in which to carry out the suicide plan. The nurse should be particularly alert to sudden lifts in mood. Chlorpromazine or Thorazine is a first-line, first-generation antipsychotic. Has a lot of heavy-duty side effects. Teach your patient to get up slowly from a lying or sitting position to minimize orthostatic hypotension. Also, medications that are used are anti-Parkinsonism agents. They are used to treat the extrapyramidal side effects of antipsychotic drugs. Also, anticholinergics, the one I want to mention is benztropine, brand name Cogentin. That is used along with usually haloperidol, brand name Haldol. If you see a patient taking Haldol, look for benztropine or Benadryl. Okay? Diphenhydramine. Brand name Benadryl is an antihistamine with strong anticholinergic effects, also used to treat the extrapyramidal side effects of the antipsychotics. Okay, these are the medications, some of the medications used to treat positive symptoms: haloperidol, loxapine, chlorpromazine, flufenazine. The nurse must monitor for extrapyramidal effects, which are dystonia. These are involuntary, unintended muscle contractions. Akaesthesia is the inability to remain still. Pseudoparkinsonisms. Okay, they imitate the symptoms and appearance of Parkinson's disease. slowed movements, muscle stiffness, and a shuffling walk. Tardive dyskinesia, or TD, are the movement disorders that cause a range of repetitive muscle movements in the face, neck, arms, and legs. So those are the side effects that you can have with the antipsychotic. So teach your patient, because the anticholinergics, they're going to have a dry mouth. Teach them they can chew sugarless gum. They should eat high fiber foods, drink lots of water, and be aware of postural hypotension. Second generation atypical antipsychotics. Okay, they are used to treat negative and positive symptoms. Risperidone, olanzapine, quetiapine, ziprasidone, and clozapine. Okay, and here's the client education. Low calorie diet, regular exercise. They should have blood tests monitored for a granulocytosis, which is a low blood cell count. Adverse effects, there may be agitation, dizziness, sedation. And third generation example is aripiprazole or Abilify. Decreases the risk of extrapyramidal symptoms or tardive dyskinesia, lower risk for weight gain and anticholinergic effects. So weight gain in any of these medications, your patient may stop taking them because of the weight gain. Antidepressants, the example here is paroxetine, which is brand name Paxil. Okay, monitor for suicidal ideation. Okay, can increase thoughts of self-harm initially. Very important assessment for the nurse. Should not stop abruptly. Okay. Mood stabilizing agents and benzodiazepines. Valproate. Valproic acid, lamotrigine is Lamictal, lorazepam is Ativan. Okay, nursing actions, use with caution, and educate your client that they may get sleepy, dizzy when they're taking these. Okay, lastly, teach your patient they should stop smoking. Smoking has been identified as a health risk for clients with schizophrenia, okay, and because of the obvious health risks of lung diseases and cancer. And also smoking has been found to decrease the effectiveness of some of the psychotropic medications. Okay, and that's it. That was a long one. I'm glad you hung in there. And we'll see you on the next one. Look out for the psychopharmacology. Have a great day.